If you can just state your full name and your title, that would be great.
Naghma Khan, and I'm a pediatric emergency physician. I was the former division director of pediatric emergency medicine, and I've been practicing pediatric emergency medicine for 25 years.
Wow. So you've taken care of a lot of children.
Yes, I have.
Now you're taking care of your grandchildren too, right?
I am actually, yes.
Well, that's good.
They're young. One's going to be 2 in about 2 months, and the other is just turned 5.
Wow. Okay. So you have a lot of personal as well as professional experience in dealing with sick children.
Yes.
That's good.
Yes, I do.
Yeah.
Traumatized.
Yeah. Well, so I wanted just to spend a little bit of time kind of getting your perspective on, illness in babies. Obviously you and I have talked about the device that we're making, nasal suction device, and kind of how colds and upper respiratory tract infections affect, particularly young babies and feeding and breathing and all that. So I don't know, in your grandchildren, is it your daughter or your son?
I have 4 daughters, so this is my oldest
Okay.
daughter who's going to give me a 3rd grandchild soon.
Wow, great. So maybe, discuss, like, I'm sure your daughter calls you periodically and says, okay, one of the grandbabies is sick. What should I do? How do you approach, maybe a 6-month-old who has a bad, runny nose, cough, can't breathe, versus a 6-week-old versus, a 2-year-old? I mean, I don't, I assume that those are different things in your mind, and you probably tell your daughter different things based on those ages and symptoms.
Yeah, well, and maybe we can even go back a generation, because I have 4 girls. My youngest, who was born in 1996, happened to be born during the RSV season. And I spent many sleepless nights with her because she had bronchiolitis. Started off with a mild cold and congestion, and went deeper into the lower respiratory tract. And she had a lot of respiratory distress. I actually had to bring her into the ER. At that time, if you think back all the way to 1996, we tried a number of different modalities for bronchiolitis. As a matter of fact, still in our national meetings, every year there's a bunch of studies on how to treat bronchiolitis. We have tried everything, but in the end, the only thing that ends up working is nasal suctioning. So at that time, she was actually given a treatment of racemic epinephrine, and then we were given some racemic epinephrine to take home by my colleagues so that I could do this at home. She was breathing about 60 to 70 times a minute. So I stayed awake with her for 2 or 3 nights, and honestly, suctioned her very frequently. She cried constantly. She wasn't able to eat. She had more reflux than usual, so she wasn't tolerating her feeds very well. Lasted about 3 or 4 days, and then she gradually got better. And, that's now in the past, and she's 24 years old.
Wow.
My daughter, who's my oldest daughter, has 2 children, and she doesn't trust any of our medical therapies at all. So she's absolutely happy with just doing nasal suctioning. So it used to be a bulb suction for a 5-year-old, and then we graduated to a nose Frida for common colds and congestion. And these kids,
the one where you're suctioning on the tube, and then the other end goes in the.
Yeah, so it definitely better than a bulb, which really did not help a lot. And from my own personal experience, it caused a lot of trauma in the nasal passages. There was some bleeding. It was very uncomfortable for the child, and you never got a really good suction with a regular bulb suction, which we still use, sadly, in the ER all the time, and parents get when they go home after having a baby, that they always get a little bulb syringe to go home with. So the problem with that was you never got a good suction. You really weren't ever able to suction them well. And then, now it was the nose Frida. When I tried it on my grandchildren, I figured that would definitely work better because it created a suction on the outside of the nostril. But maybe I'm going too far ahead for you. When the kids are young, they're in the 0 to 3 month age group. It's a very different thing from when they get older. And definitely as they get older and they're able to blow their own noses, there's usually no need for a suction device because they can blow it out or suck it in. On the other hand, when they're younger and they can't blow their own noses, we are basically helping them blow their nose with whatever suction device we choose to use, depending on the era the child is born in and what the parents have. So also, the they are obligate nose breathers as infants, and so anytime their nose is obstructed, they really don't have the ability to open up their mouth and breathe fully through their mouth. In addition, we go ahead and either put a bottle in their mouth and they've got to now suck against a nose that is completely blocked, or they have a pacifier in their mouth, which also makes it difficult for them to breathe when their nose is completely blocked. If you imagine an adult having an obstructed nose and trying to constantly just breathe through the nose, that's the feeling these babies have. So it's very important to keep the nasal passages open in a hygienic way.
Right.
During my fellowship, I actually had a patient come in who was 2 months old, and the mom had tried to clear her nose up by blowing through the mouth and actually gave her bilateral pneumothoraces.
Like where lung gets around, or air gets around the lung and they can't breathe very well.
Yes, and so now they basically the lungs blow up like a balloon and pop, and now you have air outside the lungs and they can't breathe. So the child came in severe respiratory distress, and we had to intervene on the child's behalf. And that's a very common way that parents have of clearing out nasal passages, in a very unhygienic way, more unhygienic than anything else that we use. But it does the job for most of the time, but it can cause serious side effects. So moving from blowing in the child's nose to actually sucking out directly by putting their lips directly on the nose and
Right.
sucking nasal secretions, we've seen that happen as well, maybe less dangerous than blowing in the mouth, but definitely extremely unhygienic.
Until COVID-19. Yeah.
Yeah, definitely. Yeah, and RSV, a virus that actually causes most of the problems in little babies, causes a common cold in parents. And so you're basically, getting the infection. And if you have other kids or even the same kid, you're constantly transmitting infections back and forth by doing something like that. Maybe the bulb suction is not as bad, keeping the bulb suction clean, big issue. You still got to wash it, at least with soap and water, to prevent it from getting really dirty and even collecting mold inside because it is so moist. Then moving on from the bulb suction to obviously the nose Frida. And then and there's a number of electronic devices on the market, which I have never personally tried myself, but those were my two experiences. So as kids are older, not too bad. As kids are younger, we see a lot of visits in this age group in the winter. That is basically our primary volume in the ED, is kids with upper respiratory infection or a combination of upper and lower respiratory infection, which is bronchiolitis.
Yeah. And so you mentioned RSV earlier, and I know it is a big health hazard. Obviously COVID-19 is on everybody's top of mind, but I know personally that RSV is a big problem. I mean, what do, parents look for? Obviously they don't know if their kid has RSV necessarily, but, what are the parents that are kind of bringing their kids in to the hospital, in the middle of the night or whatever? What are they experiencing? What are they looking for? Kind of what do you look at or assess when they come in?
So the common complaint that they come in is, my child isn't breathing well, or my child isn't feeding well, because they have such a bad cold and congestion and nothing's working. And some of them are coming in the first day of illness. And if you think about it, all these viruses tend to get worse over time. And so when you see them on the first day, you don't know which way they're going to head. Are they going to progressively get worse and get really sick? Or are they just going to have a mild illness, and by day number 3 or 4, they're recovering, and over the next 1 or 2 weeks or even 3 weeks, they're getting better? The duration of illness tends to be long. Their arrival is really based on my child is not acting right, or not breathing right, or refusing to feed, or not able to suck on the bottle. And at peak of illness, these kids tend to get dehydrated because they're not able to suck on the bottle enough. So they're not getting enough in. And because of swallowing a lot of air, they tend to regurgitate more. They tend to vomit. And so they're not keeping enough down. Even if they get it in, it's coming out. And so they're not able to stay hydrated. The third thing that happens is some of these kids have fever as well. Fever increases the insensible losses, so the child is now losing more water from their body. And so in combination, not taking it in, regurgitating it out, and then also having fever and having increased losses from the body makes them highly prone for dehydration
Right.
by day number 3 or 4 of illness.
So say, as you gave the example, they're coming in, it's the first night of the illness or whatever, and you're like, well, you might be able to go home, obviously cleaning out the nose as we discussed. Is there anything else that they can do besides using a nasal suction device, or any other thoughts about that?
So you're saying when we discharge them home, if
Yeah,
they're
say they don't seem, for whatever reason, they don't seem like super ill. I mean, just because some of these families, they come back and forth, back and forth, back and forth, and so the first time they come in, you're like, well, I don't know where this is going to go, but obviously being in the hospital with a bunch of other really sick children isn't the best place for them either.
absolutely.
So if you send them home, say, okay, keep, the nasal suctioning is important. Are there other things that you recommend that they do?
Yeah, so when I see a patient like that, I do ask the respiratory therapist to just do a regular suctioning on them and educate the parent on how to do bulb suctioning.
Yeah.
So, which is the thing that we have in the ER right now. So show them how to do it. We don't have any other way of suctioning them, so I can't educate them on a different way. But I say your job is to help the babies clear out the baby's nasal passages. The way to do it is to dilute the secretions in the nose and then suck them out. So we actually will educate them on that. And then if they're well hydrated and their respiratory distress is not significant and they're able to suck on a bottle, they're ready to go home. Usually this is a winter disease. Heating
Right.
is on at home. So I always tell them, keep the heating turned down low. You don't want it extremely warm. You don't want hot air blowing on your child constantly, because that'll increase their losses from their body, and it'll dry up their secretions as well. So keep the heating turned down low. They're probably going to be more comfortable sleeping in a more upright position. That's why they like to be on the parent, with the parent holding them, but you can't leave him like that. So if they have a bassinet, I say, if you have a bassinet, put some pillows underneath the bassinet to keep the head of the bed elevated. That's one of the things I tell them to do. I said, if you don't have a bassinet and they're sleeping with co-sleeping, I said, I don't make a judgment call on that. That's very cultural in my mind. So I say maybe the car seat, or if you have a separate baby seat, have them sleep in that. Their head will be propped up more because you can't put a pillow underneath their head. Right. So that's another thing that I suggest to them. I say it's very important for your baby to drink. So if you're breastfeeding, breastfeed them more frequently. Burp them frequently between your feeds. And if you're bottle feeding, then also offer them the bottle more frequently, giving them small amount of feeds multiple times through the day. So hopefully they'll keep that down. Right. Suction them before you feed them and before you put them to sleep. Because if they are sleeping comfortably, the parent will get some sleep. This is going to be 2 or 3 days of sleepless nights for the parent, because the child's not going to sleep well. So whatever we can do to make both the child and the parent comfortable. And then the things to look for is progressively worsening breathing difficulty. So they're not even able to latch onto the breast or onto the bottle nipple, because they're having such a lot of breathing difficulty. Their belly is moving up and down. If they're not getting any wet diapers in an 8-hour period, they're falling behind on fluids. And if you can't get anything into them, we should be seeing them frequently. If they are not behaving normally, so they're normal, they should be crying more. They are going to be a little bit more clingy. When kids are sick, they tend to be clingy. If they are not interacting with the parent in their normal way, that would be a concerning feature as well. Bring them back to the ER. So tell them to keep a very close eye on the child for the first 3 or 4 days, because that is kind of the litmus test of them getting worse before they get better. And maybe the same care provider providing care during that time, so they can see that progression, so that they can recognize it. If there are different care providers during this 3 or 4 days, they may not recognize that the child is getting worse, because they're just seeing them on that one particular in that one particular time. So that's difficult, but usually grandparents step in. That's that's what I do with my kid if I don't have a shift. To let me take care of them so you can get some sleep. Right. So that's kind of really what I do. It's easy to make the decision to admit the child if they're coming at day number 2 and they already look sick. You know, they're going to get worse before they get better. I'm going to bring them in. They look sick on day 1. They're going to get worse. They're going to come in for 2 or 3 days for observation. If I see a child with some moderate respiratory distress and it's already day number 3 or 4, I can reassure the parent and make sure they follow up with their primary care physician the next day. If their oxygen saturations are fine, if their respiratory distress is not so severe that they cannot drink a bottle, they can go home.
Yeah.
Sorry about that. Otherwise, that's my daughter. Sorry, it came on that. Otherwise, we'd be admitting a lot of patients, and we do run out of beds in the winter, and it's predominantly because of RSV. If you think about it, nowadays with COVID-19, ER volumes are down 50%.
Wow.
When there's RSV, the volumes are up. I mean, our volumes are usually 160 to 200% of what our normal volumes are in non-RSV season. So all of these ED visits are related to RSV, all the way from fall, all the way to March or April of the next month, RSV and influenza, obviously.
Right. Yeah. And so say if the child does need to be admitted to the hospital, you know, or kind of, you know, as you said, in the wintertime, you know, you're at 200% capacity. So they may be having to stay in the emergency room for a period of time. Other than nasal suctioning, what other kinds of therapies or things can you offer the child?
Hydration. And hydration does not necessarily have to be IV hydration. You could NG hydrate them. If they're not requiring a high level of oxygen, you could put an NG tube in, which is, you know, 100% success in the first go, compared to putting an IV in a little infant who is already dehydrated. That's always a tough task for our nurses.
Right.
So besides suctioning, hydration. Honestly, there isn't much else that we can do. There's a number of modalities. They try hypertonic saline. It hasn't been proven to be effective in the emergency department. And the hospitalist service, I think they tried. There's no harm in trying something, true? So you can give them a trial of albuterol just in case there's a strong family history of asthma, or the child has eczema and atopy. It may be possible that their viral infection is precipitating an asthma attack, but that's usually not even a consideration in kids less than 12 months unless they've had multiple episodes of admission for wheezing. That's my grandson. We will read afterwards, but I'm on the phone, okay? So just go inside for a second.
And then I've seen them in little tents or something, you know, in the humidity tents or something like that.
So we don't do that anymore. I think if we move to if the child has significant respiratory distress, we will try high flow oxygen on them. We move from low flow to high flow. Low flow in a little 2 or 3 month old is going to be 2 liters of flow. Anytime you're hitting 4 liters of flow through the nose, you are going into a high flow, basically giving them 100% oxygen. Those kids usually end up in the intensive care unit for closer monitoring. But requiring a little bit of oxygen or a little bit of flow, which can help them with their work of breathing, we can put them on the floor.
Yeah.
Humidification, only from the perspective of maybe loosening up their secretions a little bit. I don't think that's been proven to be effective as well, so we don't do that. Like I said, if albuterol works, we will continue to use albuterol. Epinephrine, same thing. If it works, you can give a trial of 1, but make it closely evaluate the child for efficacy, because if it's not working, then you're just giving them a medication that will have more side effects rather than be helpful. So there isn't much that helps. Obviously, if they're in respiratory failure, or if they're starting to have apnea, which is another side effect of RSV, where they are now having periods where they're not breathing, probably because they've just tired out their respiratory muscles and they don't have the drive left to breathe. We have to put them on a ventilator until they're recovering from the illness. So this can be a very severe illness in a very small percentage, but in the majority of the kids, it tends to be mild to moderate illness and they recover from it.
But other than keeping the secretions clear and the nose clear and supporting them, that's really about all you can do.
Absolutely. That is the only thing that has been proven to be efficacious in this illness. And it doesn't have to be RSV. Honestly, you can get bronchiolitis from RSV and any of the other influenza, parainfluenza, adenovirus. Anytime a child gets a cold, it can track down into the lower airway as well
Yeah.
and increase secretions. And that's what causes these symptoms that very much look like asthma, but are not asthma and don't respond to albuterol.
And so once, hopefully these children or your child that had, bronchiolitis recovers and you're going home, you know, as far as keeping the temperature reasonable so they're not, burning a lot of excess fluids and suctioning their nose. I mean, I assume humidification in the room is reasonable. Anything?
That's reasonable. Yeah,
Yeah.
a mist humidifier, keeping the heating turned down
Yeah.
at home, dressing them comfortably for whatever the temperature is. And parents sometimes will overdress their kids as well, which causes them to sweat underneath
Sure.
all those layers of sheets. I always tell them, if you're
Right.
cold, your child is cold. If you're hot, your child is hot. So be aware of that.
Right. Okay. Well, and so how do you, I mean, so in your house, or in your daughter's houses, how do they manage, the temperature, the humidity, those kinds of things? Because you're right. I hadn't, yeah. I mean, bundling, you always want your kid to be supported and warm, and you put them on those fuzzy, very fun, good feeling PJs, but then you walk in the room is hot and the kid's sweating and is miserable. I mean, how do you tell families to manage, or how does your family manage, that?
So, yeah, what I tell them is keep the temperature comfortable, not hot. You'd be surprised how hot people keep their homes. When
Yeah.
you ask them, what is your thermostat setting, it's usually 78 or 79. And
Wow.
it's hot.
Yeah.
And it's not just the heat that the room achieves or the house achieves. It is, you're constantly blowing hot air through the ventilator. There's no heating device that's not going to be working overtime to keep it to that level when it's so cold.
Right. Right.
So I always tell them somewhere between 68 to 72 based on your comfort, based on the parent's comfort level is where you should keep the temperature, so that the heating is not constantly on, that it has periods where it turns off and the room normalizes a little bit. And then the humidifiers, I mean, it's very easy to say, go buy a cool mist humidifier. Not everybody can afford to do it, definitely not in our patient population. I use Spalding, I say, just take, because if there are other kids at home, I don't want them to get some hot water and kind of steam it up by boiling it on the stove or keeping a hot pan somewhere close to the vent. I just say, get a little pan of hot water and put it where the hot air is coming out. If you can do that, that'll hopefully catch some humidity as it's coming out. That's one way of doing it. And then, of course, the positioning of the baby appropriately. My daughter won't even give Tylenol, so I talked to her about it. But she says fever is the body's way of fighting off an infection, which is absolutely appropriate. Let the body do its job. So I always say, treat the fever. If it's above 101, 102, or your child clearly looks uncomfortable with the fever, otherwise let it ride its course. And don't do that just for my family, but I also say it to the parents as well. I think we overtreat fever, which creates a fever phobia, which also then causes an ED visit because people are petrified that their child has 101 fever. Because we notice it in the ER, a nurse always says, hey, the fever is 101, you want me to give some Tylenol or Mofin? So, that's the way. If the fever is high, I believe in treating it only because my evaluation of a child with a high fever is very difficult. They look sick, their face is flushed, they feel miserable. So if you bring the temperature down and they still look sick and their behavior hasn't normalized and they haven't forgotten that they have a fever, that's really concerning to me.
Right.
They should immediately get up and want to play or drink or eat or do something, because children don't fake illness unlike my husband does.
The man cold, you want to talk? We can talk about the man cold if you want.
We absolutely can. He always moans and groans when he gets a cold.
Yeah, no, that's funny. Well, good. I mean, any other kinds of words of wisdom to impart on, folks that are going to look at this and, are kind of, particularly first-time parents are kind of going through this and figuring it out.
Yeah, don't put a pillow under your baby. If your baby has no neck, they don't get a pillow. And I think that is one mistake they tend to make, because they feel like when they have a cold, they have to prop themselves up on a pillow. They will immediately prop the baby's head up on a pillow, and that potentially can cause airway obstruction. And so that's a no-no. If they want to elevate the head of the bed, the best way to do it is to put pillows or bricks under the head, when you have a crib, just at the head of the bed, you can put 2 or 3 bricks on the head side of the legs, or put 2 or 3 pillows under the mattress, so the mattress tilts, slants down.
Yeah.
So that would be one way to do it. Or if they're in a bassinet, put a pillow under the bassinet itself.
Got it.
For the little babies. But yeah, it's tough. I think um, finding a nasal suctioning device that you're comfortable with. I like the nose feeder because it creates a really good suction on the outside of the nostril. And I actually tell the parents to use it like a neti pot. Actually, put the saline in one side as you're suctioning from the outside, so you can backwash the secretions, and so that works really well.
So, what do you think about that in COVID-19?
So concerning, obviously, right now, because the nose feeder, you're sucking with your mouth, and with even without COVID-19, even though they say that there's a valve that prevents secretions from coming up, if you have a lot of secretions, the secretions don't come up, but the germs are definitely coming up as you're creating the suction. Yeah. We know that, there is the aerosolization of COVID-19 as well, and even the droplets, honestly, will come through that valve. So you want something that you don't have to connect to your mouth.